Good morning and welcome to the November edition of the Within Summit Education Series. My name is Jamie Singletary and I am the Director of Family and Alumni Programming. Today, you are going to hear a presentation on ARFID Basics and Beyond by Clinical Lead Elisha Wilkins and dietitian Cathryn Williams. Before the presentation, I would like to just go over a few housekeeping items. You will receive an email to the address that you registered for this presentation. That email will contain a survey. Once you complete the survey, you will then also be given a link to download your continuing education certificate. During the presentation, our presenters are going to allot a portion at the end for questions. So please utilize the chat box to ask your questions. I will also place my email in the chat box if you have any concerns or issues obtaining your certificate. So without further ado, I will turn over to our wonderful speakers. Enjoy the presentation.
Good morning, everyone. Thank you so much, Jamie, for that warm welcome. And thank you to Jamie and the Within team for opening this presentation up today to the greater eating disorder community. ARFID is a topic that is near and dear to me and Cathryn as well, and we both have experience treating individuals with ARFID at higher levels of care and see that there are many more opportunities in our eating disorder industry to provide effective and novel treatment approaches for this population. So some of the things that we want to ensure that we cover today in our talk, these are our objectives for today. We want to describe the diagnostic differences between ARFID and anorexia nervosa. We want to learn ways to utilize a food hierarchy in the assessment of ARFID. And then lastly, we want to specify treatment interventions and also highlight ways to treat this population in higher levels of care and also a virtual environment. Let's take a look first at the diagnostic overview in the DSM-5. So when we think of ARFID, ARFID is not really a new diagnosis as it did replace the DSM-4 diagnosis of feeding disorders of early infancy or childhood. And that was really with the advent of the DSM-5 in 2013. ARFID is really just the newest form of disordered eating to be recognized, again, in the mental health community. Many think of ARFID as picky eating, and today we really want to highlight that ARFID is not just picky eating or disordered eating. It's really beyond that as well. So with the advent of the DSM-5, taking into consideration what we previously saw in the DSM-4, the age of onset criterion was removed in the DSM-5 as feeding disorders were previously limited to those under the age of 6. The weight loss criterion was also removed because what we know about ARFID is not always defined by weight loss. Children may not lose weight when they do have a diagnosis of ARFID or even gain, but they may not grow in terms of stature or height as expected. And the DSM-5 also acknowledged some of the psychosocial stressors and physiological consequences of ARFID that Cathryn is going to highlight today when we get to a slide on nutritional deficiencies. And the DSM-5 did move the diagnosis from a feeding disorder to an eating disorder. So ARFID, we want to take into consideration 3 things. If you look at the slide, apparent lack of interest in eating or food, avoidance of food based on sensory characteristics of food, and concern about aversive consequences of eating. In individuals diagnosed with ARFID, they may have one of those characteristics, they may have 2, or they may have a combination of all 3. So when we are assessing for a diagnosis of ARFID, we really want to prioritize what is the primary maintaining mechanism here. And we also know that clients with ARFID have one of the following: nutritional deficiencies, dependence on supplements or tube feeds for nutrition, as well as significant weight loss, failure to achieve expected weight gain or stagnant growth, And something that was also highlighted in the DSM-5 is marked interference in psychosocial functioning. And so with some of these changes, that really opens up the ability for us to look at novel treatment approaches as well as additional interventions. So when it comes to the epidemiology of ARFID, we know that there are higher numbers of patients in pediatric inpatient eating disorder programs and pediatric day treatment or partial hospitalization programs with a diagnosis of ARFID. We also see a higher number of individuals diagnosed with ARFID that are male. One study identified 67% of individuals with an ARFID diagnosis as male. We also see significant psychiatric comorbidities such as anxiety disorders, obsessive compulsive disorder, attention deficit hyperactivity disorder, autism spectrum disorder, as well as developmental delays. These individuals are more likely to have a history of picky eating that then morphs into disordered eating. Their texture or sensory aversions, fear of vomiting or choking, food allergies, abdominal pain, or nausea. What we also saw are fears related to contamination, in addition to fears or around individuals or seeing another person vomit or choke, or seeing individuals as well experience nausea or difficulties with swallowing. And ARFID is also a risk factor for later onset eating disorders. Psychological concerns, as I mentioned before, part of the DSM-5 diagnostic criteria is marked interference in psychosocial functioning. So what we know is that avoidant and restrictive eating really gets in the way of daily life activities. So think back to when you were an adolescent. What was very common for you all to do was engage with friends. Adolescents want to fit in with their peers. And as a result, due to some of the eating issues, individuals will avoid sleepovers with friends, lunch at school with peers. Family dinners at home become very difficult, and the ability to travel becomes difficult because these families have to really think about how their child or their adolescent are going to get adequate nutrition as well. We also see social stigma and isolation. There's fear and embarrassment that goes along with this. There's a fear of going out into public places due to some of the aversive consequences that may have been experienced. And then also we want to look at the disruption of family functioning. The family may accommodate the disorder at home by going to certain restaurants or going to certain stores to buy particular food items as well. So we want to assess that as well and address that in some of the work that we do. Let's take a look at ARFID versus anorexia. Many of you have probably heard that there are really no shape concerns or body image concerns, but some of the more recent studies do see low levels of shape concerns in individuals with ARFID. Both are restrictive types of eating disorders. However, ARFID is more about avoidance and resistance. And we do see, as I mentioned before, a higher proportion of males diagnosed with ARFID versus females, essentially 2 to 1. As I mentioned before, 67% of males in another study were identified. Individuals with ARFID are not concerned about weight. These kids want to gain weight. They don't have many of the same obsessive thoughts that we see with anorexia. There's a much earlier age of onset. So typically we are going to see kids diagnosed with ARFID under the age of 10. There's also higher levels of food neophobia, and that's a reluctance to eat and an avoidance of new foods, which makes some of the interventions associated with ARFID much difficult to intervene with. So let's talk about psychological assessment. So to screen for ARFID, it is recommended to use a screening tool for other eating disorders in combination, for instance, with an assessment such as the PICA ARFID and rumination disorder interview, or the NIAS, which is the 9-item avoidant restrictive food intake disorder screen. The EDQ is also used to assess other eating disorders and to rule out ARFID. So I've highlighted the top three there at the top of the slide. So for instance, the party has 4 versions. There are 2 versions for parents and caregivers based on client's age. There's also a version for children ages 8 to 13. And then there's also a version for adolescents and adults ages 14 and up. So this assessment not only assesses for ARFID, but it also looks at the severity across the 3 subtypes as well. And this is really helpful for us when it comes to identifying treatment targets. The NIAS was designed to detect ARFID symptoms and additionally assess the 3 subtypes that were previously mentioned that also align with the ARFID presentation. So many clients, as I mentioned before, will still have just one presentation. So this assessment is really helpful for clinicians when it comes to prioritizing treatment targets. A couple other assessments that were used in some of the research are, for instance, the Power of Food Scale, otherwise known as the PFS, and this is a food availability subscale, and this is also helpful in separating out anorexia from ARFID. And then we also took a look at the Food Neophobia Scale, in addition to the Eating Pathology Symptoms Inventory. So those are also helpful when it comes to sussing out, is the diagnosis anorexia nervosa or is the diagnosis ARFID? And then we want to look at some of the maintaining factors. And as I mentioned before, PARTY and the NIAS are really designed to assist clinicians in conceptualizing symptoms in this 3-dimensional space. So we know that in essence, these cycles are maintained by the physical and psychological consequences experienced as a result of ARFID. And as we will see later on, CBT-AR is a modality that was designed to really target some of these maintaining mechanisms. And by having a better understanding of these maintaining mechanisms, that really essentially helps us to better inform our care. So let's talk about the selective eating type. So when it comes to selective eating, individuals are born with a predisposition that causes them to experience the sensory characteristics of food much more intensely than others. So for instance, bitter tastes are strong and aversive. And then again, that prevents those individuals from wanting to engage in food exposures. Those individuals are reluctant to try new food. And as a consequence, their diet then consists of food that they consider safe and familiar. And there's also a maintaining mechanism of disgust. So the pattern is maintained by the disgust of trying new foods. We also want to take a look at the poor appetite or lack of interest in eating. These individuals also have a predisposition where food is found to be less rewarding. They may also experience low hunger. And because these individuals worry about fullness, they may experience joy in even trying new foods, like is for many of us, there are limited opportunities for exposure. And then lastly, the fear of aversive consequences. These individuals have a pre-existing anxious temperament, have negative thoughts around food, are sensitive also to bodily sensations, and as a result, avoid food, new foods, all foods in an effort to reduce the likelihood of that trauma occurring again. So again, we often see, as you can see in this infographic here, we also see an overlap of these presentations, and prioritization is really helpful when it comes to treatment planning.
Now we'll jump into a nutrition assessment, and you'll see here just some basics when it comes to things that we're assessing upon an initial assessment. Some things that I want to highlight that I think are really helpful are growth charts. That way we can really see what was going on at the time of the presentation of the ARFID. Do we have any history of some growth, falling off growth curves earlier in life? And then I also think it's really helpful to have parent insight. That way you can really see from the parents them say like, oh, when my child was 2, he was a very picky eater and we were so worried and we tried so hard to get him to eat green beans. So that really helps us have a better view of some of those negative behavioral occasions that have happened around food from an early stage. And last, you'll see on here vitamin and mineral deficiencies, which we'll jump into a little bit more in. So here's a list of some common nutrient deficiencies that we see among ARFID clients. Some of these things we are routinely examining on a complete metabolic panel, things like calcium, vitamin D, iron, but there are things like folate and vitamin A and vitamin K that we're not routinely looking for. There is an instance of a teenager who had essentially lost his vision due to the malnutrition from having a very limited diet of having chips and crisps and sausages and processed hams to the point where he lost his vision. So this is something that I think we need to be very acutely taking a look at with our clients with ARFID. So I know these are not the most beautiful photos, but I think it's a really good representation of what we can do in this virtual setting. So there is something called the nutrition focused physical exam, which many dietitians are trained in. That is very hands-on, is a lot more extensive when you're in person, but I wanted to highlight here that there are some things that we can do in this virtual setting when it comes to a nutrition focused physical exam that we can be seeing that we might want to be investigating more when it comes to nutrition deficiencies. We can see people's hands, we can see their teeth, we can see some of these characteristic signs of some nutrient deficiencies through this virtual setting. And last thing that we'll do during a nutrition assessment is the hierarchy of foods. This is a image taken from the CBT AR workbook. And I will say this one is very detailed. I think it's like 5 or 6 pages long, goes through all the different foods, all the different food groups, which is a really helpful tool to have all the details when it comes to where are we starting, what are those safe foods, and what are foods that we can start experimenting more with. And here's just a continuation of that same one from the CBT AR workbook. Now, I also like this. This is just a different way of looking at the hierarchy of foods. We can have that very detailed version. Here's a little bit more simple, clean, kind of visual when it comes to the hierarchy of foods. Our green foods, meaning the ones that are safe, ones that we're incorporating right now. Our yellow foods are ones that we can begin with some of our exposures when it is time for that. And then our red foods might be ones that are a little bit more long-term, things that we maybe are going to be thinking about doing a few months from now, a few weeks from now, just depending on what the client's needs are. So just some goals for treatment here: achieve and maintain healthy weight, correct those nutrient deficiencies like we had talked about that we're seeing in the assessment, eat foods from the basic food groups, which we can go into a little bit more when it comes to how we include those exposures, and feel more comfortable when it comes to situations involving food.
And to date, there are no well-established treatments for ARFID. There are some that we're going to highlight today, and there are some that are also in the process of being developed. And so in addition to these goals that are outlined here, another thing that I would consider adding into one of these treatment goals is really working with clients on the development of adaptive skills that will also assist our clients on any one of those goals of treatment.
So I really like this visual when it comes to nutrition goals. So essentially we want to start at the bottom of that pyramid and move our way up. Our main goal when we're first seeing clients is, are we getting enough food to support them in the malnutrition that they may be experiencing? And from there, working our way up the pyramid, ultimately getting to more of those instrumental foods, meaning foods that are also enjoyable, but also might be supporting our overall health. So initial meal plans when we are seeing clients with ARFID, like I said, our first big goal more than anything is just really supporting our clients and getting enough nutrition in. So whether that may be we are providing more food for them on the plate than what they were before. Maybe we're increasing how often that they're eating throughout the day. Maybe temporarily we need to use a supplement like Ensure, Boost, or homemade shakes or something like that to really support just getting enough nutrition in. Hydration is definitely one that sometimes can get missed too with these clients. So sometimes with ARFID clients, they not only struggle with getting enough food in, but also getting enough fluids in. So we might need to use some foods that might be more hydrating, things like applesauce or puddings, yogurts, things that are going to be naturally hydrating for the client. And then lastly, getting some vitamins or minerals on board, depending what the client's deficiencies are. What's missing from my plate? So this kind of takes into account where we start thinking about those exposures. So I always really like to take the hierarchy of foods and kind of put it next to this my plate visual when I'm thinking about exposures and deciding where do we start. So currently in the client's diet, what food groups are represented, what foods aren't. So this can kind of help figure out what would be most important when it comes to exposures to do first, second, and kind of moving around so that we can really support a client in having a versatile diet. Exposure therapy. So like Elisha said, there's no one which way of doing some of these exposures. There's a lot of different modalities that have been used, but here's just a couple ones that we have used with clients when it comes to exposure therapy. First off, that could be increasing the amount of the preferred foods that we have, and then feeding in smaller amounts of those novel foods. I kind of put it in a visual of maybe we have a plate of pasta and then there are 2 or 3 green beans on the plate that we're doing the exposure with at that meal. We can also do ERP and using the fear of food measures in more of a one-on-one kind of setting. And then lastly, food chaining. So I always really like this visual of how we might take someone from eating, let's say, McDonald's French fries, and we're trying to really build up, as you can see. So we might start with McDonald's French fries, and then we're making homemade fries at home. Then we're going to make some sweet potato fries and just kind of build up from there. For other people too, it may just be being able to get chicken nuggets from maybe a different restaurant or different place. Maybe we start with Tyson chicken nuggets, and this week we're going to try Purdue chicken nuggets instead. Really just supporting the client in how can we expand beyond where they're at currently.
The next few slides are going to focus on therapeutic interventions, and CBTAR is a modality that was developed by Jennifer Thomas and Cameron Eddy out of Harvard University. And this is a manualized treatment utilized on an outpatient basis. It's about 20 to 30 sessions. It does have 4 modules. The first module does focus on psychoeducation. The second focuses on psychoeducation about some of the nutrition deficiencies that Cathryn discussed, as well as how to select novel foods. And there's also typically a focus on increasing volume for those that do need to weight restore, and focus on variety as well. Section 3 selects modules based on the subtypes that we reviewed previously. So there are in-session exposures as well as homework practice. And then number 4 is a relapse prevention plan. So this plan is available in 2 formats. So there's a family supportive CBT-AR. So typically we will involve the parents along with the child or adolescent during the session, especially if the child is under the age of 16. If the child is age 16 to 17 and they need to weight restore, then we'll also involve the family in those sessions. Anyone else will have a combination of individual CBT-AR in addition to family involvement, primarily including the psychoeducation as well. So out to the side here, I have a picture, an infographic of this book. If you haven't read it, really encourage you to pick it up. It's a great read. It's a great way to learn a little bit more about this manualized treatment. The workbook that Cathryn referenced earlier as well is something that you can download for free from Harvard University as well. It also has some amazing infographics as well that you can use in there when it comes to psychoeducation with clients and families. FBI ARFID, this is actually one of my favorite things about ARFID. This was developed by Nancy Zucker and her team down at Duke University. And this FBI is Feelings and Body Investigators. And this is a modality that she originally developed for children with functional abdominal pain. It's also been used in the treatment of panic disorder as well as IBS. And FBI specifically targets the food avoidance subtype. The goal here is to really focus on being able to really identify why children and adolescents avoid food due to some of the internal sensations. This modality assists children and their parents with learning to understand emotion and bringing some attention to emotion and meaning to some of the sensations that they experience in their body. There's also an element of teaching coping skills and self-regulation. There's about 10 sessions that focus on things such as learning to guess what that sensation that you are experiencing in your body means. My favorite part is the playful cartoons. We've got individuals such as Julie Jitters and Gassy Gus. I know it's hard to see on the screen, but go to Google FBI ARFID, and you'll see some of the colorful infographics that we use when it comes to this modality. And really the goal here is to learn strategies that slow down the body sensation, making it easier for these children to eat, try some of the new foods, and really see the sensations as no longer threatening. It also teaches coping skills. So for instance, when you feel nervous, can you hold your parent's hand? Can you hold a friend's hand? So it really goes through some practical strategies that can be used in the home setting and then can also be used in other community settings such as school. And other therapeutic interventions too that have not necessarily been widely studied in the treatment of ARFID are, for instance, utilizing an occupational therapist or speech and language pathologist really to determine the appropriateness for exposure therapy, especially those that have that fear of aversive consequences. We want to ensure, especially if part of their treatment is really going to involve a significant number of exposures, we want to ensure that there are no swallowing difficulties that would impact our ability to do the food exposures. Again, psychoeducation is really a hallmark of working with individuals with ARFID and providing the parents with education about the origin of these behaviors and how they're maintained as well. Cathryn highlighted the utility of exposure therapy. We also want to develop specialized group content. Many of these individuals are not going to be appropriate for process groups. So we want to develop some specialized groups that will work for these individuals, such as social skills groups, anxiety management, DBT and CBT groups that focus on helping these individuals to better understand their emotions and what the emotions are telling them to do. And the goal is also to help challenge some of these unhelpful thoughts, learn more adaptive skills, and teach the clients to understand what happens when their emotions are in charge versus when they are in charge of their emotions. Mindfulness and somatic techniques work really well, especially because we do see that individuals with ARFID have a high level of anxiety. And then again, that social skills training, as we talked about before, isolation, withdrawing from peers is a very common thing that happens with individuals with ARFID. So working on some of that social skills training so we can work towards incorporating back into their school and community environment. When it comes to multidisciplinary treatment, some of the studies did highlight the utility of treating ARFID successfully with only a therapist and physician without a large multidisciplinary team. Much of the research did recommend focusing on a diagnosis or an assessment by a pediatrician or a primary care provider or even a behavioral health provider before adding in additional team members. And some of that's due to the anxiety that we see with individuals diagnosed with ARFID. And as I mentioned before, getting an occupational therapist on board or speech and language pathologist as well, who can do an assessment prior to beginning some of the exposure work. Much of the research really highlighted treatment for ARFID at higher levels of care. It's especially important when it comes to reducing ARFID symptoms in adolescents for those that do have severe nutritional deficiencies or need to weight restore. Treatment at higher levels of care is especially important, again, when we need to focus on those elements, especially the resolution of nutritional deficiencies. Treatment at higher levels of care also affords clinicians the ability to do food exposures more frequently or for the purpose of reinforcement. And there is access to a multidisciplinary team. So next steps, we have the ability at Within Health, being in a virtual environment, going into the client's home virtually really affords us the ability to engage parents and assess if ARFID is being accommodated in the home. I've certainly worked with some individuals where parents are traveling, for instance, and I'll talk with the family about, well, how are you going to feed your child while you're on this trip? And parents will have a plan. You know, we're packing up their preferred foods. We've talked with the chef at the hotel, and they're going to make all these specialized foods as well. So being in the home really does afford us the ability to do a comprehensive assessment, because part of treatment will involve also making changes in the home. So in essence, we are there. Being able to bring parents into a session to discuss what foods to buy for exposures. We have access to the parents in a virtual environment. Other things to consider are what assessments will be most helpful. Clearly, we need psychological assessments, we need nutritional assessments, and then we also need a thorough medical assessment as well. Because of some of the involved sensory issues, creating what I like to call a sensory section in the client's room, maybe a special place in the client's home where they can go when they are feeling extremely anxious, and they can practice some of the adaptive tools that we have taught them in treatment as well. And again, that's something that we are able to do in a virtual environment, being in their home. We want to take a look at movement and activities as well as somatic experiences. Movement is really important for these kids. With other eating disorders, as many of you know, we are decreasing exercise, but we want these kids, and I say kids, but we also know that ARFID is something that we see in adults as well. But because of the anxiety, we want them to have ways that they can get their jitters out, so to speak. We want to be able to provide them with exposure opportunities. Also providing treatment at a higher level of care allows us to do exposures at times that are not at their actual meal times. And that's one thing that we want to be able to do, whether it's at 10 in the morning or 2 o'clock, every day of the week. We want to be able to provide those consistent exposures. And we also want to bring the parents into treatment, because we want to teach parents how to do these exposures at home for when the child or adolescent is away from the treatment program. Cathryn spoke a little bit today about meal hygiene, social skills training. Again, many of these individuals who have been diagnosed with ARFID have been isolated, and certainly the pandemic has not helped some of that isolation as well. So we want them to have a group that's specific to social skills and opportunities to practice some of those social skills out in the real world setting. We want to have a CBT and DBT group. And again, we can do this in a virtual environment with many of the offerings that we have from 8 in the morning all the way up to past 8 p.m. in the evening. There are many different groups and modalities in which we can plug in our clients. And we can do family coaching and education that is specific to this diagnosis. And the important thing is we really want to better understand the maintaining mechanism, whether that's sensory, it's the fear of the aversive consequences, or it's the lack of interest in eating. We want to really understand those maintaining mechanisms so we can arm our clients and we can arm our parents with the tools to move forward.
So just to expand a little bit more on how we can include these exposures in programming, just like we've said previously, there's no one which way of how to include these exposures. It really depends on the individual needs of the client. So for some, this might mean that they're going to bring their typical meal to a programmed meal, and they'll have an exposure along with it. This could also mean that we have a one-on-one session with a care partner or the dietitian or a therapist to do more of those one-on-one exposures around some foods. Something that we also like to include is doing an exposure log before and after, just to really measure and follow up the team of what things went well, where was our anxiety at, were we able to complete the exposure, and where are the next steps from there. This is something that from my years working in pediatrics, I find to be really important, and something that sometimes can be missed is, I think, part of really rebuilding that relationship with food can come from even before you sit down at the dinner table, sitting down with your meal or whatever it may be. We might see some clients and children, like Elisha said, that their experience has been very much like this top picture. They might have had some experiences where mom and dad have been really forceful in trying to push this process along. And we really want to help foster some of those interactions so that we can get closer to what this bottom picture looks like. So I'm not sure if anyone has read it before, but one of my favorite resources with ARFID clients is Helping Your Child with Extreme Picky Eating. It's a step-by-step guide. And in this book, there is some very detailed tools that we can use when it comes to really setting up a meal for success. So sitting down for a meal, can we get distractions out of the way? Can we put some music on in the background? What are some coping tools that we can have available? So something that I love about the virtual setting is we can include a lot of these things in their treatment since they are at home. They have a lot of these comforts that we can be including in these exposures to really support our clients with their goals. I know Elisha hit on it as well, but the family education piece I think is huge to really recircuit some of these things that we might have been doing at home previously.
And what I just want to add to that too is, going back to what we said previously, is that ARFID is not picky eating. We know that picky eating can resolve itself on its own, and that kids eventually outgrow picky eating, but kids do not outgrow ARFID. And since the advent of the ARFID diagnosis in 2013, we've also seen more adults come into treatment with ARFID as well, who probably had feeding issues that then morphed into ARFID, and no one knew back then what to call it. So we know that with the right type of treatment, individuals can get better and move past this diagnosis. And as you've seen today, there are many important things that we want to focus on and look at: the psychosocial stressors and interference, as well as some of the nutritional deficiencies, as well as some of the medical factors that we did not highlight today, as we do not have a medical professional here with us as well. But those are important things to look into as well, and to be diagnosed when we work with this population as well. It truly does take a team and a village and all of us coming together. I also want to add that the food exposures with these individuals are fun. Not only are they stressful for the clients, and they're fun because as I mentioned before, these kids, they truly do want to get better, and helping them learn to map some of the sensations and the emotions onto their food avoidance and their food resistance can certainly help us move past some of that as well. So these are some of our resources. I want to make sure we get you all the resource for the free resource that we talked about today, which is the workbook as well. So I'll make sure to pass that link on to Jamie as well. Certainly want to make sure everyone has that resource. But we do certainly want to open it up to questions. I know we focused mostly on children and adolescents today. Like I said, ARFID is something that does affect adults as well. So certainly don't want us to lose sight of that.
Thank you so much.
Stop the share so I can see everybody.
Thank you so much, Elisha and Cathryn. There was a request for the workbook link. Yes, so please share that. There was a request for the workbook link. Does anyone else have any other questions? Please don't hesitate. You can utilize our chat feature. You can send it to everyone in the group, or you can just send it to the panelists. If you have any feedback, concerns, or comments regarding the presentation. We have a quiet bunch today. I know you guys can't see them, but
we can't see them.
They are out there. I can attest they are out there, but they are very quiet this morning. Since we do have a couple minutes, are you all? I see. Let's see. Oh, we have a comment. Wonderful and helpful content. Thank you so much. So you all are getting praise.
Maria. I am going to share the link for the workbook in 1 second. I just have to get it.
We do have a question or a comment. It says, wondering if restaurants are good places for food exposures.
They can be. I would say probably not initially, but absolutely can be. And for some, the exposure may be just trying to have more than one place to eat out at. I was at a training recently, and one of the presenters was talking about their client who mom was going to 3 different fast food places every single day because all 3 children had very specific needs. So it might just be, how can we make things a little bit easier? Can we get the chicken nuggets from Wendy's instead of, can we get them from McDonald's or whatever it may be? So I think definitely doing some restaurant exposures can be helpful.
And I'll add to that with the exposures too. One of my very first clients when I started working intensive outpatient about 15 years ago, I look back now and clearly this individual had ARFID. We just didn't know what to call it back then. She came to us on about 1,500 calories of supplements. Her repertoire of food, she was eating about 5 foods, and again, when individuals are needing to do weight restoration as part of this diagnosis, before we even start doing the food exposures, we focus on increasing the volume as well. So the pasta that she was eating that had the 4 other ingredients in it, basically was eating several times a day just to get some of that consistent nutrition coming into her body along with the supplements. And then outside of the regular meal times is when we were doing the exposures as well. So that's very common to see individuals come into treatment with a very small repertoire of food. Whether I've had some clients with 5 items, 8 items. There's sometimes brand preferences. We talked a little bit about some of the selectivity before as well. And sometimes it's a brand preference. This particular individual would only have ragu spaghetti sauce because of it's finely pureed. If any of you have had ragu before, and it's like water. It's, there's no chunky tomatoes in there or anything. So we sometimes see that as well.
We do have another question. What recommendations would you all have for helping parents understand how ARFID can be treated in a remote environment? Thank you, Sean.
Yeah, I think, Sean, that's a great question. I think highlighting what we can do, being in their home, having access to the parents. The dietitians certainly can work with the parents on assessing what they have in the pantry. We can provide coaching around the food exposures as well. We can work with the clients on setting up that sensory section that I spoke of before too in their room. So when they are having high anxiety around food, or experiencing some of those uncomfortable sensations, they have that sensory section that they can go to as well. So we are able to do some of that work in a virtual environment with our clients. And again, involving the parents is going to be a huge piece of this as well. Cathryn, I don't know if you have anything else that you want to add. The only other thing I'll add too is we have such a wide range of groups available, CBT, DBT. We can do somatic work as well. We can do the mindfulness. We can do some fun movement exposures as well, because we don't want to take movement away from these individuals. We want to add movement because we want to help them work through some of this anxiety so that they can work through the food exposures as well. So it's really a combination of DBT, CBT, parent involvement in coaching, exposure work, mindfulness, and somatic work, if I had to kind of highlight the top as well.
And that goes into our next question. How about exposures? How are these set up when there is not a dietitian available?
So I will say, if the exposure is done in, let's say, a programmed meal or snack, the dietitian will inform the care partner that they are doing this exposure, we'll have it written out for them and the expectations for that exposure. So there is communication that happens even if the dietitian is not physically there for the exposure. And then same thing if an exposure might be done one-on-one with a care partner instead. There's that communication between the dietitian and the care partner to ensure that that they feel comfortable doing that exposure and what the expectations are.
And I would say best practice would be actually to have a therapist and dietitian together during that exposures. In our virtual environment, because we do have a wide range of disciplines, we could have the care partners doing the meals, and then we could couple the dietitian and the therapist during the exposures, because the dietitian is working on, remember, volume and variety. And the therapist could be working on those uncomfortable sensations that the client is experiencing in their body and helping them in real time to be able to use some of those adaptive skills that they have been learning throughout the treatment process. I'm also a huge proponent of therapists being involved in meal support and coaching as well. So I've certainly worked in environments where sometimes it's a handoff. Sometimes the therapist is doing the exposures and sometimes the dietitian is too. But again, in a multidisciplinary team environment, regardless of who is doing the exposure, you have access to your other team members as well. So one of the benefits of multidisciplinary teamwork.
So to add on to that question, to clarify, if you're a therapist and a client is perhaps resistant to seeing a dietitian, how would we facilitate the exposures?
Yeah, I certainly think what we can do is, again, we can couple the two individuals together and bring that dietitian in. That in of itself is an exposure. We can have the therapist working through the meal support and the coaching. The dietitian, kind of think back to FBT as well. If you look at standard manualized FBT, it's primarily driven by a therapist, and in some places you might have a dietitian kind of in the background. You could start out that way too, get small commitments, small exposures to involving the dietitian as well. The dietitian is, however, key in this because they do really need to assess that food hierarchy that Cathryn showed everyone a little bit earlier. That food hierarchy does help us to know which foods we do need to start out with in the exposure. It's typically 5 foods that we will start out with, and then we gradually add to it as well and work through that hierarchy as well. Cathryn, anything you'd add to that?
Only thing that comes to mind is routinely in our program, a client would be seeing both a therapist and a dietitian. So I think we're not seeing this scenario as much where a client would, let's say in the outpatient setting, like maybe only be seeing a therapist or a dietitian, depending on what's going on with the client and availability. So I think we're not seeing this as much. We try to keep things very multidisciplinary and really be working as a team to support these clients.
And I think in our virtual environment, we're setting up that expectation on the front end that you will be working with a multidisciplinary team. You will have a food specialist, you will have a dietitian, therapist, care partner, etc. I think you're more likely to encounter this scenario in an outpatient setting. And what we know from the manualized based CBTAR is the recommendation is starting out with a therapist and a physician and adding in other team members as you see appropriate.
And just to echo what you both are saying, as the director of family programming, that is one of the things that we go over in the family orientation group before the clients are even admitted to our program, is that expectation of who they will be working with and the role of each person that they will be seeing while they're in our program. So that is communicated very, very early on. And I think that also speaks to Sean's question regarding the family involvement and how to get the parents on board. We're very clear on the value in their input and their participation and how that helps the probability of changed behavior after the treatment program has concluded. Any other questions from our audience? We thank you all so much for sharing the space and time with us this morning or this afternoon, depending on where you are. And we want you to stay tuned, as this is something that we're going to continue to do on a monthly basis. We will actually be doing these for CE credit more and more. So please be on the lookout to see who's coming up next. And don't forget to utilize the email address that you registered with to obtain your continuing education certificate. And always check our website at withinhealth.com for other things that we are offering in our community. Thank you, everybody, and have a wonderful day. Thank you, Elisha and Cathryn.
Thank you, everyone.